audio course on pet and gestational hypertension. Episode 3, Diagnosis Without Chaos. Let us begin in triage. A patient is 34 weeks. The automated cuff reads 152/98. She says she has a headache, but she also has not eaten and did not sleep. The urine dipstick is 1+. The fetus is moving. The room is busy. This is where hypertensive disease becomes chaotic if you do not have a diagnostic order. The order is simple. First, confirm the blood pressure correctly. Second, decide whether there are severe features. Third, quantify proteinuria properly. Fourth, assess maternal organs. Fifth, assess the fetus and placenta. Sixth, use biomarkers only as a clinical adjunct, not as a substitute for judgment. Start with blood pressure technique. The patient should be seated, with feet supported and the arm at heart level. The cuff size matters. If the cuff is too small, the pressure may be falsely high. If the patient is lying flat late in pregnancy, supine hypotension and positioning artifacts can confuse the reading. ISSHP recommends using devices validated in pregnancy and preeclampsia and measuring both arms initially. If the pressure is non-severe, persistence matters. ACOG and ISSHP use repeated readings, typically at least 4 hours apart, to confirm true hypertension. That protects the patient from being mislabeled because of pain, anxiety, movement, or measurement error. But if the pressure is severe, do not wait 4 hours.
Severe means systolic at least 160, diastolic at least 110, or both. ISSHP says repeat within 15 minutes. ACOG says confirm within minutes when needed, so treatment is not delayed. The reason is stroke prevention. A 4-hour confirmation rule makes sense for diagnosis. It is dangerous for severe hypertension. Once hypertension is real, ask whether this is isolated hypertension or preeclampsia. Proteinuria is one route into the diagnosis. The classic threshold is at least 300 milligrams in a 24-hour urine collection. But the modern workflow usually does not need to wait 24 hours. ACOG accepts a spot protein to creatinine ratio of at least 0.3. NICE, ISSHP, and SOMANS use protein to creatinine ratio at least 30 milligrams per millimole, or albumin to creatinine ratio at least 8 milligrams per millimole. The point is not that these are magical numbers. They are practical thresholds that identify clinically meaningful proteinuria quickly enough to guide care. Dipstick is not enough. It is cheap and available, but false positives and false negatives are common. ACOG warns about poor reliability. NICE says that if dipstick is positive, quantify it. SOMANS says dipstick can screen, but cannot confidently diagnose. Now the most important proteinuria rule. Proteinuria diagnoses. It does not stage severity.
Once preeclampsia is established, repeating the amount of protein usually does not decide delivery. The patient with 3 grams is not automatically more urgent than the patient with 1 gram. Severity is driven by blood pressure, platelets, creatinine, liver injury, pulmonary edema, neurologic symptoms, fetal status, and gestational age. Next, check maternal organs. The minimum lab set is platelets, creatinine, and liver enzymes. If there is concern for HELP syndrome, DIC, or hemolysis, add LDH, blood smear, coagulation studies, and fibrinogen, according to local practice. Platelets below 100,000 are a severe feature in ACOG and the Hadassah protocol. Creatinine above 1.1 milligrams per deciliter, or doubled from baseline, is a severe feature. Transaminases at least twice the upper limit of normal are a severe feature. Pulmonary edema is a severe feature. Persistent headache that does not respond to medication or cannot be explained by another diagnosis is a severe feature. Visual symptoms are a severe feature. Do not let the word symptom make you casual. In this disease, symptoms may be organ warnings. Right upper quadrant pain may be liver capsule tension or HELP syndrome. Chest pain or dyspnea may be pulmonary edema. Headache and visual symptoms may be cerebral edema, vasospasm, PRES, or impending eclampsia. Nausea and vomiting in the wrong context may be hepatic disease, not simple pregnancy discomfort. Now assess the fetus and placenta.
At diagnosis, obtain fetal growth assessment when gestational age allows, amniotic fluid assessment, and umbilical artery Doppler if growth restriction or placental insufficiency is suspected. Antenatal testing, such as NST or CTG, follows gestational age and local protocol. Guidelines differ in how they label fetal disease. ACOG does not call fetal growth restriction a severe feature by itself. ISSHP and SOMAS place uteroplacental dysfunction more directly inside the definition of preeclampsia. But all agree clinically: a small fetus, abnormal Doppler, oligohydramnios, abruption, or fetal compromise changes risk. Now, where do angiogenic biomarkers fit? SFLT1 to PLGF is not another urine test. It is a placental biology test. It asks whether the circulation shows anti-angiogenic imbalance. In prognosis, a ratio of 38 or lower was excellent for short-term rule-out in suspected preterm preeclampsia. NICE recommends PLGF-based testing to help rule out suspected preterm preeclampsia between 20 and 36 plus 6 weeks. ISSHP recommends adding angiogenic testing when available for suspected preeclampsia before 37 weeks. SOMANS is more cautious about using it as a diagnostic criterion. The rule is, biomarkers refine risk. They do not rescue a dangerous bedside picture. Now, let us handle the differential diagnosis. Renal disease is the classic mimic. Chronic kidney disease can cause hypertension and proteinuria before pregnancy. Baseline creatinine, baseline proteinuria, urine sediment, hematuria, casts, and postpartum persistence help separate chronic renal disease from preeclampsia. But remember, renal disease and preeclampsia can coexist. Lupus nephritis and antiphospholipid syndrome can mimic preeclampsia with hypertension, proteinuria, thrombocytopenia, renal dysfunction, and fetal growth disease. Complement levels, anti-dsDNA, autoimmune history, thrombosis history, and urine sediment may help. HELP syndrome overlaps with TTP, HUS, acute fatty liver of pregnancy, viral hepatitis, gallbladder disease, and pancreatitis. If hemolysis or thrombocytopenia worsens after delivery, or the renal and neurologic picture is atypical, do not assume it is ordinary HELP. Neurologic symptoms require respect. Headache and seizure can be eclampsia, but they can also be migraine, cerebral venous thrombosis, intracranial hemorrhage, ischemic stroke, epilepsy, tumor, infection, or metabolic disease. The correct stance is not to ignore preeclampsia and not to ignore neurology. It is to stabilize the mother and investigate when the story does not fit. Finally, remember pheochromocytoma and secondary hypertension when the blood pressure is extremely labile, refractory, or accompanied by episodic headache, sweating, palpitations, or hypokalemia. It is rare, but missing it can be fatal. Let us close with the diagnostic sentence.
This is chronic hypertension, GHTN, PET, or superimposed PET at this gestational age, with or without severe features, with this maternal organ status and this fetal placental status. If the sentence is incomplete, keep evaluating. The resident reflex is this: do not diagnose hypertensive pregnancy from a dipstick and a single cuff reading. Confirm the BP, quantify proteinuria, look for severe features, check maternal organs, assess the fetus and placenta, and use biomarkers only as an adjunct to the whole clinical picture.